Um, Hi everyone. Thank you so much for joining us tonight. I'm Anushka. I'm the Programs and Operations Associate here at SAAPRI. And with us tonight, actually, SAAPRI's Executive Director, Shobana Verma, is also present here. And she's joining us via mobile because she had a conflicting commitment. But I'd still like to thank her for joining us tonight. She's great and she's always committed to making all our events and being a very, very active leader. But on behalf of her, let me just quickly introduce Sapri, and then I'll hand it off to Prottusha. As you all are aware, SAAPRI is a nonprofit, nonpartisan organization, and we were established in 2001. We were volunteer led up until I believe a couple years back, and our mission is to serve the South Asian American community by using research to, formulate equitable and socially responsible policy recommendation. So, as part of our mission, SAPRI is dedicated to improving health and access to our community. And today's webinar is possible due to our partnership with the Asian Health Coalition for the All of Us research program. And I'll let our moderator, Prottusha, today share more about that. And today we also have the health equity research interns, Manaswini and Nikita, who also helped Prottusha plan this Women Health Series program. Nikita, unfortunately, was not able to make it today. She does have COVID, but she says hi to everyone. And yeah, I'll hand it off to Prottusha to sort of introduce the series and herself, and we'll have the panel begin.
Great. Thank you, Anushka, and thank you, Shobana. I know you're here for all of your support. So my name is Prottusha. Like Anushka said, I am the Health Equity Research Fellow here at SAAPRI. I'm also an MD, MBA student at Northwestern University and worked with all of these wonderful people over the past few years. And we are so excited to bring you this webinar. So just very briefly before we kind of introduce all of our panelists to you, our Women's Health Series is an educational initiative born from a passion for women's health education and awareness here at SAAPRI. The series is dedicated to addressing health issues that affect South Asian Americans throughout their lives, with our different webinars being dedicated to various concerns that occur at the different junctures in life. So in this series, we'll be discussing reproductive health, contraception, cancer prevention, metabolic health, menopausal care, and more. But as you know, this specific webinar is focused on healthy relationships, contraception, and safe sex. So like Anushka mentioned, through this series, we'll not only be raising awareness and providing valuable information on these topics, but also encouraging participation in research initiatives like the All of Us research program by the NIH. By fostering informed discussions and engaging our community in these efforts, the Women's Health Series aligns with the ARC Coalition's mission to enhance precision medicine research and to address health disparities within the South Asian American population. So without further ado, I'm going to move on to the next slide where we will introduce our panelists. So first, I'd like to invite Dr. Michelle Brown to give us a little bio about herself. You are still muted.
Yes, there is a setting that says the host doesn't allow you to unmute yourself, so you'll have to unmute all of us, just so you know.
All right, I will do that.
Great. So hi, everyone. My name is Dr. Michelle Brown. I am an OBGYN that practices at Northwestern Hospital and also at Planned Parenthood of Illinois. I have been an OBGYN for about 5 years now. I did my training at University of Chicago, and in addition to working in the OB triage unit at Northwestern, which is like our emergency room for pregnant patients, I am also involved in advocacy efforts through the American College of OBGYN. So I serve as the legislative chair for the state of Illinois.
Thank you. And the mute function should be fixed now. So if Dr. Murthy, you want to go ahead and introduce yourself.
Hi, this is Kay Murthy. I have been practicing at Northwestern as a private OBGYN for I think about 18 years or so. about 21 years in total since I graduated from residency. Did my training at Rush and then was in the Philadelphia area for a short period of time and then have been here pretty much ever since. And do broad spectrum, sort of comprehensive gynecologic care, both obstetrics and gynecology.
Thank you. And Dr. Patel?
Sure. Hi, everyone. My name is Dr. Ashlesha Patel, and I work at Cook County Health, or Cook County Hospital, traditionally known. I'm also a professor at Northwestern, and I practice OBGYN generalist. I have a area of specialty and interest in family planning specifically, but I'm now the associate chair for the department. So maybe, Michelle, you should give us a ring. We're looking for a new director of family planning. So something you may want to think about. But nonetheless, we've done a lot of research in the area of women's and reproductive rights and health. And I'm so looking forward to talking to everyone today.
All right, thank you. And last but not least, Dr. Orr.
Hi, everyone. My name is Dr. Maya Orr, and I completed my undergrad in medical school at University of Southern California, and then completed my residency training in OBGYN at George Washington University in DC. And I'm currently a first-year fellow in complex family planning here at Northwestern. I'm very passionate about sexual health, reproductive justice, and reproductive autonomy. So I'm very excited to be here speaking with everyone.
Great, thank you. And yeah, I'm Prottusha, your moderator. I already told you about me. Won't go into too much detail, but I am a student at Northwestern. All right, so kind of moving into our first topic of the night, which is healthy relationships. So I think the first topic that we really wanted to start with Dr. Orr specifically is talking about, what does a healthy relationship look like? What is a healthy relationship? How can we define that?
I'll take it away. Just I can obviously talk forever about these things, so I'll rely on Prottusha, our lovely moderator, to help me out. All right, so what are healthy relationships? So I think that the way that we can look at a healthy relationship is that it's built on several building blocks. I would say the main ones are respect, equality, safety, and trust. So when we're talking about respect, it's a two-way street, right? You want to feel that you are important to and taken seriously by your partner, and you want to also make your partner feel the same, okay? And following in that, you want to treat them that way, and so show them that you take them seriously and that you respect their opinions, their life views, and their background and who they are as a person. Equality is about making decisions together. And so you want to be able to share your dreams, your goals, happiness, pleasure, and make sure that you feel heard and that is as important to your partner as it is to you. Okay. And I mean, we call it a partnership for a reason, right? You want to be partners in life. You want to share things on an equal basis. Okay. And that also means power. So there should be equal power in the relationship, so that you can feel empowered to be yourself, and your partner should feel empowered to be yourself as well, be themselves. The third that I mentioned was safety. So this is really important because you want to be able to feel safe physically, emotionally, mentally. And again, you want to be able to feel safe to be yourself. You shouldn't feel like you have to be anyone else but yourself when it's with a life partner. And then the fourth one is trust. So trust is the foundation of all healthy relationships, friendships, or romantic relationships. And I think it's when you don't have trust in one another that a lot of toxic and unhealthy behaviors are able to grow and spread. And so you want to be able to trust your partner unconditionally. So I mentioned unconditionally very, very mindfully and thoughtfully, because I think that when we talk about unconditional love or unconditional trust, it means that there's no strings attached. You don't have to do something to earn that love or earn that trust. And, you know, the respect, love, trust should be given to you without having to read the fine print. Okay, it means their love shouldn't be thrown as leverage or thrown in your face when you're disagreeing. And so I want you to keep in mind the unconditional part when we talk about unhealthy relationships. Okay, so moving to unhealthy relationships, I find that most often people immediately think of domestic or intimate partner violence. And I apologize, I should have mentioned earlier, but I will be mentioning some possibly triggering words. And so feel free to step away or mute me or whatever makes you feel comfortable. And so absolutely a part of unhealthy relationships is the concept of having that physical or domestic violence, abuse. That's 100% unhealthy. We think about other ways that are very, very frank, unhealthy relationships, like emotional abuse, making you feel guilty, making you feel shame, self-doubt, worthlessness. We think about financial abuse, which is, again, tying back to that feeling of power and equality. So if they're holding back on you financially, if you can't support yourself and they're using that as leverage, that is an unhealthy relationship. And then, of course, there's also reproductive coercion, which not many of us speak about, but definitely an important thing to know, because bodily autonomy is something that everyone should have the right to, especially in a relationship. So reproductive coercion is when a partner may force you not to have birth control or not use birth control or not use condoms, and even may lead you to get pregnant if you're a uterus-bearing person, because they know that that gives them more power, right? So when patients with uteruses are more vulnerable when they're pregnant, because now they are relying on someone else and are kind of tied to that someone else as well. Okay. But if we think back to the kind of building blocks of what I talked about, I think we can talk a little bit more on a basic level of what unhealthy relationships are. And I like to think of it as looking back at those 4 building blocks and having a little asterisk on it, right? So, for example, in an unhealthy relationship, you can have respect with an asterisk, where I would, you know, for example, I will respect you if you dress the way that I want you to, or you don't put on makeup, or you put on makeup because I want you to, right? So that is not respect. That is kind of your partner forcing their own opinions on you. And so that's like respect with an asterisk, okay? Same with trust, right? Trust with an asterisk would be, I will trust you if you give me all the passwords to all of your devices, and you show me all your texts, and you stop speaking to all people of the opposite sex, because that makes me feel like I can't trust you, right? So that is not trust. It's trust with an asterisk. It's not unconditional. It comes with fine print, terms and conditions, and that is unhealthy and something that should immediately trigger a red flag for you. Okay. And so thinking about these unhealthy relationships, you know, for one reason or another, people may end up in an unhealthy relationship. It's not something that you should feel shame about. It's not something that's your fault. And we're only here to empower you to recognize those signs so that you know when to leave a bad situation. Okay. So in terms of resources, I think that kind of speaking about this and starting to recognize the signs of healthy versus unhealthy relationships is definitely the first step. Okay. And if you do feel like you're in an unhealthy or unstable environment, then the next step would be to reach out to loved ones, people that you trust. It could be a school counselor, it could be your residential advisor, it could be your best friend, it could be a family member. And most importantly, it could also be your doctors. It can be your primary care physician, it can be your OBGYN. Okay. We can kind of get into more detailed, like having an exit plan and a safety plan and stuff like that. But I think the most important for our discussion here today is kind of to reach out to someone you trust. And if you are not in that position, then know your resources. If you ever feel like someone may harm you or you feel unsafe and you feel that you would be able to safely call 911, you can do that. You can call 811, which is the mental health line. There's also the National Domestic Violence Hotline, which you can call or text. And there are some wonderful websites. For example, the one that I kind of use to research this talk today is loveisrespect.org. And they actually offer a live chat as well as a texting service. And so these resources are out there. And I hope that this kind of shed a little bit more light and is a good start to having these conversations with your partners and your loved ones. And that's all I got. I'll leave some time for questions.
Yeah, thank you for that super comprehensive kind of overview of healthy relationships and your terminology with terms and conditions was, I think, really helped me kind of envision what you were talking about. I guess one of something that I thought might be helpful for our participants is, and anyone can feel free to answer this question, is there anything that you kind of would advise South Asian kind of people to think about, South Asian Americans? Are there any issues in this arena that you feel like really you see a lot in your South Asian patients, if that's applicable to you?
So I'll definitely say that I obviously can't speak as a South Asian woman, but having loved ones and close friends that are, I think the first thing that comes to mind is sort of the model minority model that we kind of live by here in America. And I think that I've seen a lot of sort of pressure of women of South Asia to be a certain way, to be a respectful woman, or all the things that we talked about. And so I think that that is, if someone's imposing those views on you, as I mentioned, like what is respectful for them and what is trustworthy, etc., and kind of using your own culture against you, then that would also be definitely a red flag that I would look for. But again, I'd love to hear more from the panel and what they would like to add.
I'll just say, I mean, as a practitioner and being of South Asian descent, I certainly attract a similar looking client, sort of patient base. And I think that part of the challenge is that there's a fair amount of complacency regarding domestic violence and interpersonal violence in the South Asian population. And, that is, I think, at the crux of a lot of the need for work and for avenues like this where we actually talk about it. I think a fair number of families have interpersonal violence and DV and other all other sorts of sort of oppression and suppression that they've seen either directly in their own families or in very close by. And there's I think that by asking the right questions at the right time and allowing patients to speak openly is the best, sort of the best thing that, we can do. I can do as a provider. And it is definitely something that we ask, at each of our our visits. And, and I think, even though we ask doesn't mean that someone's going to tell. But without asking, there's no way to know. Right?
I think one of the other things that culturally we are challenged with is, the American culture, sort of South Asian culture, varying degrees in which families interact with these, as our cultures sort of intertwine and how we fit in there. And, as we're speaking about relationships, I think our family relationships are equally important in terms of healthy versus unhealthy, and really do start to inform the way that we might form, let's say, romantic partnerships as well. And so I think as we as a community think about these things together, we have to think about not only the partnership relationships, but really we have so many partners in our lives, and how we've grown up, how those relationships are shaping the way we see ourselves, and the way that others see us, really impacts the way that we develop partnerships in the future. And it's hard not, you've got to sort of break down all those pieces of the puzzle to recognize when you're not in the right space. And it may be someone else who sees it and then has to sort of almost show you the mirror when you don't see it yourself. So I think it's also, whether you're a medical student or some of our student life is taking feedback when it comes. And it's not always easy when someone is saying, have a look at what's going on and think about it differently. It's not always such an easy thing to do. So not an answer, but just certainly acknowledging the questions.
Yeah, thank you for that kind of South Asian specific insight. I just wanted to move on kind of to the next topic just to make sure we have enough time for everything. So our next topic is actually safe sex. And I wanted to invite Dr. Brown to kind of give us her framework for thinking about safe sex, and kind of these two categories.
Yeah, thanks so much. So when we're talking about safe sex, there's kind of these like two broad categories of protection that we're talking about. And in addition, I'd sort of also add on a third category that kind of nicely ties in with what we were just talking about, which was that safe sex where you feel safe emotionally, and is also an important component of safe sex, where you trust your partner and you feel like you can assert the necessary boundaries, and all of that are critical pieces of a safe and healthy relationship. And so, in addition to sort of the nuts and bolts of STIs versus pregnancy prevention, that is always something that we are also thinking about when we think about safe sex, which is your emotional safety and feeling trust with your partner. But to go on to some of the medical topics, safe sex in terms of STI prevention, when we talk about that, we want to make sure that there are obviously sexually transmitted diseases that exist. So things like syphilis, chlamydia, gonorrhea, HIV, HSV, which is the virus that causes herpes, HPV, which is a virus that causes cervical cancer. These are all bacteria or viruses that can be sexually transmitted and that can be, acquired through sexual contact. So when we talk about trying to have safe sex and STI prevention, the most important way to stay safe during sex is prevention and knowing your own status. Being able to know your status on these different STDs is really important to be able to communicate with your partner. And so there are many places around the city where you can get free or low-cost STI testing. If you see a doctor on the regular, even your primary care doctor can almost always test for these diseases. Sometimes it's a blood test, sometimes it's a swab that you would put in the vagina. And so these things are available, and I'm gonna put a link in the chat that is a link to a Cook County public health website that lists a bunch of clinics in the city that do low cost or free testing for STIs. When we're talking about prevention, the main method of STI prevention during sex itself is barrier methods, which for most people means condoms if you're talking about a heterosexual intercourse, but could also mean dental dams if you're talking about other kinds of sexual contact that are not just penis and vagina intercourse. And so condoms and dental dams are basically different shapes of latex. Condoms go over the penis and provide a barrier between the penis skin and the vaginal skin. And dental dams are sort of like a flat sheet of latex that kind of serves as a barrier between like oral vaginal sex, oral anal sex, oral penile sex. So that can be used in sort of other sexual contexts. You can also turn a condom into a dental dam by cutting the tip off and flattening it out, and by cutting out down the tube side of it. Using barrier methods like this is a very effective way to prevent, the most effective way that we have to prevent STI prevention and STI acquisition during sexual contact. One of the things that is another excellent way to think about STI prevention for one particular STI in particular, which is HPV. And HPV stands for the human papillomavirus. And this is a virus that the vast majority of people in this country have been exposed to. I think it's like 75 or 80% of people in the United States have been exposed to HPV in their lifetime. Most patients contract it and then their immune system clears it away. But for a small minority of patients, that virus ends up sticking around and can contribute to cervical cancer and head and neck cancers in the future. The best way that we have to prevent problematic things like cervical cancer due to this virus is by getting vaccinated against HPV. So the Gardasil vaccine is a vaccine that has multiple different strains of high-risk HPV in it. And usually as part of the vaccine series, that vaccination series goes from about, like it usually starts around age 12, 13, and there's a 2-shot series that you get to try to reduce the risk of contracting HPV in the future. So the best time to get vaccinated against HPV is prior to any sexual contact. So that's kind of where the timing of that lies. And it has done a lot of really miraculous things for the reduction in cervical cancer rates in countries where we have seen widespread adoption of this vaccine. And so it is definitely something that if you haven't heard about this vaccine against HPV from your doctor, I encourage you to bring it up with them at your next appointment. Then another thing to know is that for if you have had unprotected intercourse, if you are having intercourse and you are concerned about HIV transmission, you can talk to your doctor about post-exposure prophylaxis. So patients who are victims of sexual assault or have a known exposure with someone who's HIV positive can take HIV medication after sex to try to reduce the risk of actually catching HIV. This is something that is screened for, and so it doesn't mean that every time you have unprotected sex, you need to go get this medication, because it's kind of based on risk factors and the status of the person that you're having sex with, but it is an option that is out there if that is something that is of high concern. And then that's kind of the overview on STI prevention. Barrier methods are the best thing we have because they protect not only against pregnancy, but against all these bacterial illnesses and viral illnesses. And there are some options for post-exposure prophylaxis for HIV. And HPV prevention with Gardasil is the best thing that has been invented in medicine in the 20th century. For pregnancy prevention, I know Dr. Murthy is going to talk about kind of the nuts and bolts of methods of contraception, but I just wanted to highlight that condoms do double duty in terms of protection. They protect against STI transmission and they protect against pregnancy. So they're great and we love a condom. One of the things that, we think is important to mention is that sometimes male partners can be resistant to using condoms. And that is something that, as Dr. Orr pointed out, that should be a red flag to you, because if that is something that is important to you as well, and it should be, that men having resistance to condoms due to the feeling of it, or they're worried about the being constricted or that it won't fit. These are excuses that men tend to use, or people with penises tend to use a lot, in order to avoid having sex with condoms. And you shouldn't put up with it, because sex with condoms is extremely important for these two reasons. And some of these viruses can be with you for your whole life. So we want to make sure that you know that men who have excuses for not wearing condoms don't deserve to have access to you. And then for pregnancy prevention, in another, if you happen to have unprotected intercourse and you are concerned about pregnancy prevention, there are forms of emergency contraception that are available that you can take after unprotected sex to reduce the risk of getting pregnant. Plan B is probably the most common one that most people have heard of. It is available over the counter. So you can just walk into a pharmacy and buy it, and it doesn't require a prescription. It doesn't require ID, and no one has to know about it. And that is a method of emergency contraception that is best taken within 72 hours, so 3 days after unprotected sex. There's another form of emergency contraception called Ella. This has a benefit of being effective up to 5 days after unprotected intercourse, but it does require a prescription, so it's a little harder to get. However, if you walk into any Planned Parenthood, they can write you a prescription for Ella that day and actually hand it to you. So this is something that is, not impossible to get if you're, say, 4 or 5 days post unprotected intercourse, but it's a little trickier than just walking into any Walgreens. So I will let Dr. Murthy kind of get into the details about other forms of contraception that are, great for long-term prevention of pregnancy. But I just wanted to highlight that condoms and emergency contraception are also things that are out there and available to you. And yeah, that is all I have for that. Happy to field any questions.
Great. Thank you for that overview. I did want to go into some kind of frequently asked questions on safe sex to kind of see your point about questions. I was thinking, we could do kind of like a rapid fire answering of these questions between the four of you. You kind of already talked about why you should be protecting yourself during sex and how you can protect yourself during sex. And kind of using it for the different types of sex. I guess I wanted to field the first question here to Dr. Patel and ask, people have asked, can the pill or other forms of contraception protect me from STIs?
Well, yes and no. So I think but truthfully, so to the comments of before, the best method to protect against STIs infection is a barrier method. So condoms or the dental dam. Yes, sometimes they're not seen as sexy. Sometimes they can be seen as constrictive. They can be challenging for some or irritating. But truly, I think we can't say enough about these methods for the purpose of protecting and really forming that protective barrier. Now, there are definitely other forms of prevention, so that certainly the pill and some of the hormonal methods do have some barrier and protection in terms of changing cervical mucus. So you might hear about that, and that can be helpful. It can also be that there are films available that you can place in the vagina, or again, as we talked about, some of the prophylactic prevention for HIV. So there are other methods, but it's really important to not, it's very interesting. And, we see in reproductive health a siloism. And I think what's great about today is we've really tried to think about breaking those down, because there are HIV people, and then there are the other STIs, and then there's HPV, and then there's pregnancy, but they're all passengers on the same bus. So when you think about this, really try not to silo yourself off to think about, oh, I'm just worried about this one thing, because they really are sort of passengers together. And it can be true that definitely safe sex, there's no question that it is the best, but I will contend to some that may be on this call that sometimes being risky is a little more fun. Let's be honest. So I think that we can't forget there are interactions that occur in a certain way that might not be perfect. And so that if you are a partner or together, you fall short of what is ideal, that doesn't mean that it's terrible or cursed or any of these things. So I think that some of this, when we try to do the best we can, whether it is contraception, whether it is a barrier method, sometimes it may not happen the way we wish. And it's important to be forgiving of ourselves when that might happen. So I think, again, especially when you're in a relationship that might be just starting, these protective measures can be very important until the lines of communication open up to be able to talking about a sexual history or a reproductive history, so that you can indeed, make decisions together if that's the way one wants to be. And again, I do want to sort of emphasize that, not all relationships are meant to be long-term, and you might have somebody who you want to just be with for today, and that's okay too. So I think that whatever the scenario might be, protecting yourself, because certainly it is difficult later to look back and say, oh, I wish I had. I'm going to stop right there.
Yeah, thank you for that. Dr. Murthy, I kind of wanted to give the next one to you. Does showering protect me from STIs or from pregnancy?
Yeah, no, I think the answer to that is no. Can't really think of any caveats to that whatsoever. Can't really, I don't know if anybody else has anything else they want to say, but certainly it's, a hygienic thing to do, but I would not rely on that for anything.
Yeah, since that was a shorter question, I don't want to shortchange you. How can I make safe sex more convenient?
Yeah. Well, I think having condoms readily or dental dams readily available, just and you can access barrier methods, usually on college campuses, at the Hall Health or Health Services. They're usually being given out for free. I don't know the exact policy at Planned Parenthood. Michelle could probably say, but I would imagine that you can get barrier method from there as well.
You can walk in and we will give you a huge bag of them.
Right. And most, I think that that's probably true of any clinic setting. The other thing we'll get to it a little bit later when I talk about contraception, but there are newer methods, like for example, which are basically vaginal contraceptives, that aren't they're not going to help with regards to prevention of STI per se, but things like Phexxi, for example, can be helpful for prevention of pregnancy by altering the vaginal pH. So, and that is, some people prefer that because it's applied, just prior to, to the active intercourse, and every time, just beforehand. So, sometimes, no matter how hard I try, I cannot convince someone to contracept either in a long acting way or in something, and, but Phexxi or is more appealing than, for example, barrier, and, takes kind of the onus off of the men. and keeps the onus on the women, basically. So anyway, just a thought, but those are my thoughts about convenience. Safe sex is not convenient. I mean, you have to, unfortunately, sex requires some forethought, and that's the whole problem with it. It's that, you know, you can't, it's, you know, it's as I always say, it is not something to be done lightly. It's a big responsibility, and you have to, you know, even when you know, there are ways to protect even after the fact, but convenience is not probably the word I would use with regards to sex.
Dr. Orr, you talked about healthy relationships and communicating with partners, kind of in this realm of safe sex. Are there questions that you've had people ask their partners in the past, or do you recommend your patients to ask their partners on this topic?
Yeah, it's a great question. I'm all about communication. I think the best way to make awkward conversations less awkward is just by normalizing it. If you don't make it awkward, then it'll be less awkward. Just ask, you know, do you have protection? How do you feel about me using a dental dam? You know, I would ask about status, and I do mean status and have you been tested? When was the last time you were tested? And as a little aside for that, I do refrain from using the words like clean, because people do use that when they're talking about sexually transmitted infections, and it really pushes the stigma of having had or having a sexually transmitted disease or infection as something that makes you dirty. And so just a reminder that the language we use is powerful. And so to further normalize, just ask about status, or have you ever been tested, and kind of where are your results. I think it's reasonable to ask to see them. If this is a partner that you are, you know, having a short-term thing or a tonight thing, or even a long-term thing. I think it's reasonable to ask to see those results because you want to be safe, and it's very easy to access results these days. I think everything is on an app at this point. So I would definitely ask about testing, and about what kind of come to a consensus about what you feel comfortable with, you know. If you've both been tested recently enough and have had no sexual intercourse or other forms of sex sense, and you feel like you want to not use protection, then that's an individual choice. So that's why communication is important.
Thank you. And I do want to touch on one last question just before we jump to the next topic. Dr. Brown, we already talked about number 7 and kind of number 9, but for number 8, someone's concerned, can they get pregnant from the first time that they have sex? Can they get pregnant on their period?
So the answer to the first question is yes, you can get pregnant even if you've only had sex one time. The pregnancy results from sort of timing in your ovulation cycle. And so if you are having sex and you happen to be ovulating, you can get pregnant if you are not using protection and not using contraception. So it is definitely something that I have seen patients come in, you know, pregnant after their first, you know, episode of intercourse. So that is something to be aware of. Can I get pregnant on my period? So like I said, you need to be ovulating when you have intercourse or around the time when you have intercourse in order to get pregnant. Now, the question is, if you're really truly on your period, the likelihood of getting pregnant is pretty low because that is sort of like the exact opposite time in your cycle compared to when you would be ovulating. So you ovulate, which is where your ovary releases an egg, and then 2 weeks later, you have a period. So if you are truly on your period, it's really, really unlikely to get pregnant. However, sometimes it can be difficult to tell if you're on your period, and not all vaginal bleeding is a period. So sometimes people can ovulate and actually have a little bit of spotting during that ovulation. And so that if you're having sex during that and you think that that spotting is your period, it could actually be ovulatory bleeding, and that is the most common, that's the most likely time to get pregnant. So if you are really religious about tracking your cycles and really consistent and are very regular with your periods, and you are, you know, able to track that and know when your period is, and it's pretty regular and predictable, then I think that, you know, you can worry less about unprotected intercourse with regards to pregnancy during your period. But a lot of people have very irregular cycles. They can have periods at unpredictable times or ovulate at unpredictable times. And in patients like that, it's very difficult to, you know, guarantee that you're not going to get pregnant.
Thank you for answering that. So now kind of moving on to that next topic that you had mentioned in your slide about pregnancy prevention. I did want to kind of talk about some methods of contraception for our attendees. So just to kind of give you a very brief rundown of what this slide looks like, and Dr. Murthy, I'll let you take over. We're just going to be talking about 3 different categories, quote unquote, based on effectiveness of the different contraceptions. And then Dr. Murthy will talk about each one, kind of how to use it, main side effects, and then a general idea of kind of cost for each of them. So Dr. Murthy, kind of feel free to take it away.
Okay. So the way that I think about contraception and how I counsel patients kind of depends on sort of where they are in their lives. And so I'll kind of quickly talk about sort of, you know, patients who are fairly sure that they are done having children, do not want to have children, then the option of permanent methods are available. And so that would be sort of this category of sterilization, whether it's female sterilization by tubal ligation or removal of the fallopian tubes, which does require surgery, or male method of vasectomy, which is typically done in the office under local anesthetic. So those are, you know, as close to 100% in terms of effectiveness as we can get, but of course are limited to, you know, kind of a smaller, perhaps, demographic compared to what we're expecting to talk about today. So that's about all. If you guys have questions about that, I'm happy to talk more about that. So that's kind of like, honestly, like the most, you know, kind of the most effective. And then sort of on the polar opposite, the way I think about it is in terms of barrier method, in terms of prevention of pregnancy, are on the other side, not in that they are ineffective by any means, but more so that their effectiveness of barrier method pales in comparison to long-acting but reversible types of contraception, things like the IUD or the arm implant called Nexplanon, and also in comparison to the various methods of combined hormonal contraception. So when we're talking about next steps in terms of effectiveness, implants and IUDs are sort of next best after sterilization. So this is a variety of different IUDs that we have. There are 4 IUDs on the market that range from 3 years to 10 years that they can be inside the uterus. And then we also have Nexplanon, which is a 3-rod implant that provides 3 years of contraception. Extremely effective, 99%, because they do not rely on anything for the patient to do per se. This is a provider, placement of the device, and so therefore also extremely effective. In terms of so for, and they each have their advantages and disadvantages and different bleeding patterns and such. I think the most important thing that I have to I tend to explain to my patients, especially my younger patients who are very hesitant about using a hormonal IUD, is that they are under the impression that the the effects of a hormonal IUD will be very similar to a combined hormonal contraceptive like a pill. And so I spend a lot of time sort of educating, re-educating patients about what having an IUD is like versus taking the birth control pill, because they are pretty much completely different in my mind. So the other sort of next step after implants and IUDs is going to be a variety of hormonal contraception. So this is going to be combined hormonal contraception. That means it has both estrogen and a progestin in it, or it's going to be a progesterone only option. And these are options that are going to be oral, like the birth control pill, of which there are so many different types. They can be transdermal, which is the patch. They can be vaginal, which is the ring. They can be injectable, like Depo-Provera, which is a progesterone only option. And each of them have, again, their advantages and their disadvantages, but they, in terms of efficacy, are sort of in the lower 90s when you think about typical use, because they do very much depend on a patient using them properly. Not forgetting to take them, not forgetting to change the patch, not forgetting to take the ring out and put a new one in, etc. So that's kind of a broad overview of them. Happy to, Prottusha, what else did you want me to comment on? So cost, I think, is one of the things you were talking about, right? So cost, for sure, sterilization and implants and IUDs are more costly upfront. Because female sterilization requires a hospital stay and anesthesia, et cetera, et cetera. We're talking, in terms of cost to your insurance, it's very, very expensive. Implants, IUDs, Nexplanon, I don't know the cost off the top. Maybe somebody else does, but most of the IUDs are going to be somewhere in the range of $1,000 to $1,500. That being said, most insurance companies do cover the cost of IUD placement and Nexplanon placement. I don't know, Michelle, do you know the cost of Nexplanon? Is it similar?
I think it's like 800 or 5 to 800 would be sort of my ballpark on Nexplanon. But again, most insurances, including state insurances and including insurances that are available even to undocumented non-citizens, cover it.
Yeah.
And the other thing, yes, there's certainly Title X programs. So again, a very important program for patients who may have little to no insurance. These are all covered entirely by that. Otherwise, there's sort of a sliding scale. So cost, for the most part, for any of these methods should not be an impetus to not embark on these methods. I think it's just, and hopefully this foray is the beginning of ways for participants to navigate or advise people to be able to acquire any of these contraceptive methods at a low cost. So cost should never be the barrier here for safe prevention of pregnancy and STIs.
Yeah, and I would say that cost-wise, for most contraceptives that are, sort of quote unquote covered by insurance, are going to be somewhere in the realm of, between, $20 and $40 a month. And for many of the sort of generic birth control pills, patch and even ring now, sometimes are going to be $0 because they are. There are generics now available. Probably the method that is going to cost the most is going to be barrier if you don't have access to to getting them for free, because condoms are very expensive. They can be fairly expensive if you're not going to go to Costco and get 100 pack or whatever it may be. But again, there are avenues in to get them for sure. And then the other sort of method that I wanted to mention I guess it's somewhere in between. I don't know what you would call it. It's a vaginal film, vaginal insert, and that's that Phexi. It doesn't really fit into any of these sort of categories. It is a bit newer. as I said, it is a situational use, so you use it prior to the onset of the act of intercourse, and works in a non-hormonal fashion, which is does appeal to people as well.
I wanted to ask Dr. Murthy, for folks who are wondering, and anyone can feel free to comment on this as well. Is this something that, if I'm on my parents' insurance or if I'm a minor, do my parents have to know? Do I need their permission to get it? Yeah.
No, you do not need your parents' permission to access contraceptive. Whether they, from a billing perspective, if you come to see me for contraceptive counseling and you're on your parents' insurance, and if they, sort of look up that code, can they look up that code? Is it plastered on the bill? No, but like there is a code for that. So in that way, could someone actually find out? In theory, at a private office where we're doing our own billing, et cetera. That is a possibility. Michelle or anyone else can talk about it from a different perspective.
Yeah, I think if anyone is ever in a situation where they don't want people to know, and there's a combined insurance plan, whether it's a partner or a parent, it's probably best not necessarily to use the insurance, because at least if there's a claim, someone else can start the inquisition, if that's what it becomes. So again, there are other opportunities, other clinics, maybe not the clinic you might go for more of your care. But whether it's Planned Parenthood, whether it's Cook County or other FQHCs out there, there are other locations that you can go to get care safely and discreetly if that's necessary. So, and also if you are potentially in school or college, the university settings, often these are available as well. So again, I think sometimes it is true, whether it's abortion care or contraceptive care, if you want things and need things to be discreet, then perhaps pursuing the insurance could be problematic.
Yeah, and I think another question that some people have posed in the past is, I know there's been a lot of stuff on, TikTok and Instagram about pain with IUD insertions, and how people are saying that it's the worst pain of their lives. If anyone wanted to comment on options for pain control during insertion of the IUD, or how painful it actually is.
No, go ahead. Dr. Patel, go ahead.
So I think that, we as a medical community, so I think this is important, that sometimes we dismiss what we do in gynecologic care as, oh, it will only hurt a little or it won't hurt at all. It's, I think we've potentially created a scenario that's somewhat unrealistic. I think many of the things we do in the field of gynecology can be uncomfortable, whether it's actually our procedure or could be some trauma prior that might be triggered by our exams. So I think that we have to be a little more cognizant of the way that we project what an IUD placement is going to be, or even an Nexplanon, although for the most part that seems to be going a little better. But I think that we need to be careful in the way that we as a medical community project what we are doing, and then take the feedback that patients are giving us, that if they say, I'm terribly afraid of this, we have to be cognizant of that. Now, the studies about use of lidocaine, are plus minus. So I think part of it is whether someone's a believer or not as a provider. But I think, sometimes we may offer things that we may not usually offer, so that for the sake of patient comfort, not necessarily that potentially, for example, paracervical block, which is injected in the paracervical area, seems very painful. And so sometimes that can be more than the IUD itself placement. So it's hard, pain perception is so personal. that I think it's important for us to get better at understanding pain thresholds and anxiety and fear that the patients bring to us. But I think for us as users of these contraceptive methods, although I'm menopausal at this point, so I have to sort of say that, but you know, that we also are honest and share that we're apprehensive, or we've never had an exam before, or that I've been hurt before. So that we can have that kind of common ground as we approach the procedure, whatever it may be.
So I think that those are, all great, it's a great point. I mean, I think I tend to be fairly transparent with my patients, and am very clear that it is, especially for someone who is younger in life and maybe hasn't, had a lot of medical intervention yet. And for many these days, like hasn't even really had their first pap smear done yet, that that it will be, an experience. And I kind of describe sort of the points of, of discomfort and how many there are, and sort of what we can do to prepare, which is usually in addition to like a hefty dose of a non-steroidal medication before the appointment, for patients who are super anxious or are, don't feel like the ibuprofen will be sufficient. We do offer them, something for anxiety and something stronger for pain that they would take in addition to the ibuprofen as well. I have also, and this is, very insurance dependent, but I have had patients who have requested that I do this under sedation. And occasionally I do that if their insurance will cover that. I think that it's important, to listen. And, there's nothing satisfying about, about trying to get to, perform a procedure with inadequate pain control. Like there's nothing quite as, there's nothing worse than that. So I think we're all pretty attuned to, we're not against, I mean, I think we all try to do our best to make sure in a field where we are accustomed to a lot of pain, seen patients go through a lot of pain, to try to navigate that with them. So there are options, I guess I would say, but it is painful. And I think I don't even know how to find a TikTok, but I can only imagine that it's not helping the cause. But I would encourage people to talk to their providers to find out exactly, what the procedure is like, and get a, a play-by-play.
Yeah, thank you for kind of going over that. I think the last question in this line that I wanted to make sure we covered before we wrap up is, are hormones bad for me? Is like taking a hormonal contraceptive method bad for me in any way? Because I know, again, people have been talking about this online, and Dr. Orr, I see you smiling because I feel like we've had that conversation several times. So I just wanted to kind of hear it, let the audience hear it straight from kind of your expertise, what you thought about that.
So I try to steer away from words like bad, because it's because on the flip side, unprotected sex that results in an unwanted pregnancy is the flip side of in terms of options, right? So I think it's all about, so if you're talking about, are there risks to taking, hormonal contraception? The answer is yes, but they're very small, right? So we think about sort of risks from a cardiovascular or like a heart health or blood vessel health, like, there are small risks of things like stroke and blood clot in your leg and things like that, but they're very, 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 very small. And yes, they're higher in people who have risk factors, but that is the purpose of having a provider who reviews your history and your risk factors to make sure that you're an adequate, that you're an appropriate candidate for the method that you're choosing. When you're talking about long-term risks of things, like, for example, people worry about cancer, endometrial cancer, cervical cancer, uterine cancer, breast cancer. For the vast majority of those cancers, there is either no association or protection from combined hormonal contraception. I think the only sort of little bit of black box is that there is some information that prolonged use of a combined hormonal contraceptive pill can slightly increase your risk of breast cancer lifetime, but that's after 10 years continuous. So that again is such a small amount that when you risk and perception of bad is relative, because the complications that can happen in a pregnancy, the complications that can happen with an unwanted pregnancy, I think far outweigh any potential small risk of a combined hormonal contraceptive in someone who's low risk, who's otherwise low risk.
Thank you for kind of talking us through that. I know we ran a little over time, so I do want to make sure people kind of get the night to themselves or the evening to themselves, depending on where you are. So fortunately, we don't have time for a Q&A, but we know some of you did submit questions. So we'll be sending out kind of like a list of resources, just like that are listed on this slide, links to kind of common questions, information. Dr. Brown shared some really awesome information in the chat here that we'll also be including in that sheet, but we'll also be answering your questions there. I just wanted to thank everyone for joining us today and for our panelists for dedicating their time to talking about this important topic with everyone.
My pleasure. My pleasure.
Thank you.
All right. Thank you, everyone.
All right. See you.